Good day, doctors. I am Dr. Timothy Nazareno, and I will be discussing case discussions with regards the previous lecture regarding esophagus, larynx, stomach, and duodenum pathologies. So for the first case, we have a 40-year-old male patient complaining of dysphagia and recurrent chest infection. Initially, a chest x-ray was requested which revealed unremarkable chest findings. Since the chest X-ray was unremarkable, upper GI series was requested next, which revealed uniform dilatation of the esophagus up to the level of the gastroesophageal junction, where a fixed narrowed region is noted, which appears bird-beak in appearance. There is subsequent egress of the contrast media into the stomach towards the duodenum. This was signed out as a case of achalasia. So what is achalasia? It is failure of the organized esophageal peristalsis causing impaired relaxation of the lower esophageal sphincter and resulting in food stasis and dilatation of the esophagus. Sometimes obstruction of the distal esophagus from other non-functional etiologies such as malignancy occurs and may have similar presentation. However, in these instances, it is called secondary achalasia or pseudo-achalasia. So the pathophysiology behind achalasia is due to a deficiency in the ganglion cells in the mesenteric plexus, namely the Auerbach plexus. This deficiency causes the following: absence of peristalsis in the body of the esophagus, marked increase in the resting pressure of the lower esophageal sphincter, failure of the lower esophageal sphincter to relax with swallowing, and abnormal peristalsis and lower esophageal sphincter spasm resulting to failure in esophageal emptying. X-ray, fluoroscopy, and CT scan can aid in the diagnosis of achalasia, but the most common test that is used for these kinds of pathology is fluoroscopy. So with regards to the radiographic findings of achalasia, it includes the following. There is uniform dilatation of the esophagus, absence of peristalsis, tapered beak or bird's beak appearance, and findings pointing out to the presence of esophagitis and ulcer formation. The next case is a 70-year-old female which has a finding of dilated aorta in 2D echo. CT scan of the chest was requested to rule out the presence of aneurysm. Initially, a chest X-ray was requested which revealed infiltrates in both lower lung lobes. However, what is concerning about this radiograph is the presence of an air fluid level at the retrocardiac region. Due to the findings seen in the chest radiograph, a contrast-enhanced CT scan of the chest was requested. This revealed widened esophageal opening as well as cranial migration of the gastroesophageal junction into the thorax with areas of the pancreas and abdominal fat herniating upwards. These findings are in keeping with a sliding hiatal hernia. Hiatal hernia is the protrusion of any part of the stomach into the chest cavity. It is highly prevalent, affecting 40 to 60% of adults. Three types of hiatal hernia are described in Brandt, which includes sliding hiatal hernia, which is the most common, amounting to 95% of cases, paraesophageal hiatal hernia, mixed or compound hernia is the last one. So this illustration shows a normal location of esophagus and stomach, a patient presenting with sliding hiatal hernia, and a patient presenting with a paraesophageal hernia. In sliding hiatal hernia, which is the most common among the hiatal hernias, the gastroesophageal junction is usually displaced greater than 2 centimeters above the esophageal hiatus. The esophageal hiatus is often abnormally widened to 3 to 4 centimeters. The gastric fundus may also be displaced above the diaphragm and present as a retrocardiac mass on chest radiograph. The presence of an air fluid level is suggestive of the diagnosis. For the rolling or paraesophageal hiatal hernia, it is way less common than the sliding hiatal hernia, so the gastroesophageal junction remains in its normal location while a portion of the stomach herniates above the diaphragm. For our third case, we have a 65-year-old male presenting with progressive dysphagia with history of weight loss. An esophagogram was initially requested which revealed tapering of the esophageal lumen. There is also marked narrowing of the middle esophagus with few mucosal irregularities appreciated in this region. A contrast-enhanced CT scan was requested. This showed a heterogeneously enhancing circumferential thickening at the middle esophagus at the subcarinal region with significant luminal narrowing. With these findings, this was signed out as a possible malignancy of the esophagus. Majority of cases of esophageal carcinoma are of squamous cell in origin. 85 to 90% of cases are within this category, the remainder of which are adenocarcinoma arising from Barrett's esophagus. This malignancy has a poor 5-year survival of 5% in cases of advanced diseases. Risk factors include alcohol and smoking for squamous cell carcinoma and adenocarcinoma, Barrett's esophagus for adenocarcinoma, history of ionizing radiation, corrosive ingestion, and carcinoma of the head and neck. So, esophageal malignancy may appear as an annular constricting lesion appearing as an irregular ulcerated stricture. It may also present with a polypoid pattern presenting as an intraluminal filling defect, an infiltrative lesion growing predominantly at the submucosa region, and lastly, as an ulcerated mass, which is the least common pattern. A CT scan is usually requested so that we could appropriately stage the esophageal malignancy so that a proper intervention can be done and to know the prognosis of the patient. So the TNM staging of esophageal malignancy is based on the American Joint Committee on Cancer and it is on its 7th edition. So for the T staging, it is graded T1 to T4. So if the lesion is under T1, there is invasion of the lamina propria, muscularis mucosa, or submucosa. For T2 lesions, there is invasion into the muscularis propria. For T3 lesions, there is invasion into the adventitia. For T4A lesions, there is invasion of a resectable adjacent structure such as pleura, pericardium, and diaphragm. And for T4B lesions, there's invasion to an unresectable adjacent structure such as an aorta, vertebral body, and trachea. So for the N status or its lymph nodes, NO is designated when there is no regional lymph node metastasis noted. N1 if there is 1 to 2 positive regional lymph nodes noted. N2 when there is 3 to 6 positive regional lymph nodes. N3 if there are 7 or more positive regional lymph nodes. For the M status, the presence of metastasis or distant metastasis is designated as M1 and M0 if there is no distant metastasis. For the histologic grade, grade 1 is well differentiated, grade 2 is moderately differentiated, grade 3 is poorly differentiated, and lastly, grade 4 is undifferentiated type of esophageal malignancy. Moving on with case number 4, we have a 53-year-old male with chief complaint of chronic epigastric pain. An upper GI series was requested. This revealed a small targetoid lesion at the body of the stomach. The rest of the stomach mucosa appears unremarkable, and there is subsequent egress of the barium contrast into the duodenum. With this, a diagnosis of gastric ulcer is considered. Peptic ulcer disease is the presence of mucosal ulceration secondary to the effects of gastric acid. Majority of cases of peptic ulcer disease are secondary to Helicobacter pylori infection. A barium meal has been frequently used to differentiate malignant and benign gastric ulcers. The following are features that are suggestive of a benign gastric ulcer. the presence of outpouching of ulcer crater beyond the gastric contour. It is smooth, rounded, and has a deep ulcer crater. It has smooth gastric folds that reach the margin of the ulcer. It exhibits Hampton's line, which is a thin millimetric radiolucent line seen at the neck of a gastric ulcer in barium studies. It is caused by a thin line of mucosa overhanging the ulcer's crater, and sometimes more often along the lesser curvature of the stomach in gastric body and antrum region are the most favorable location of a benign gastric ulcer. Now for malignant gastric ulcers, these ulcers does not protrude beyond the gastric contour. It appears irregular and has a shallow ulcer crater. It has a nodular and angular ulcer mound. It has nodular gastric folds that do not reach the ulcer margin. It exhibits the Karman meniscus sign, which is the lenticular shape of barium in cases of large and flat gastric ulcers, in which the inner margin is convex towards the lumen. And sometimes the location of this ulcer is usually seen along the greater curvature of the stomach. For the fifth case, we have a 73-year-old male with complaints of weight loss. A contrast-enhanced CT scan of the whole abdomen was requested for the patient, which revealed a large polypoid interluminal soft tissue mass within the stomach. With this, a stomach malignancy is highly considered. The rest of the visualized abdominal organs, such as the liver, gallbladder, spleen, are unremarkable. Gastric adenocarcinoma is the most common gastric malignancy that arises from the gastric epithelium. It is the most common gastrointestinal malignancy, followed by colon and pancreatic carcinoma. According to the Borman's classification, gastric malignancy may appear as the following. It may be a polypoid mass with or without ulceration, a focal wall thickening with mucosal irregularity or focal infiltration of the wall. It may appear as an ulceration with a gas-filled ulcer crater within the mass, or it may represent an infiltrating carcinoma with thickened and loss of normal rugal fold pattern. TNM staging classification also applies to gastric malignancies. For the tumor size or T staging, if a tumor is classified as TIS, means that the tumor is in situ or caught very early and has not grown beyond the stomach lining. A T1 tumor has grown through lining and into the connective tissue. A T2 graded tumor has grown into the thick inner muscular layer of the stomach. A T3 tumor has spread through outer lining but not to nearby organs or tissues, while a T4 tumor has spread into nearby tissues or organs. For the lymph node classification, N0 connotes no spread to the adjacent lymph nodes, N1 represents cancer in 1 to 6 nodes, N2 in 7 to 15 nodes, while N3, cancer is present in greater than 15 lymph nodes. For the metastatic reading, MO represents no metastasis, while M1 represents presence of metastasis. So linitis plastica is a descriptive term usually referring to the appearance of a stomach with a scirrhous type of gastric malignancy. So linitis plastica means old leather water bottle appearance. So typically, the stomach is diffusely thickened with a very narrow lumen. For the last case, we have a 57-year-old male with a palpable epigastric mass. So here we could see a heterogeneously enhancing mass at the inferior portion of the stomach near its greater curvature and in close relations with the transverse colon as well as the splenic flexure. The areas of non-enhancement exhibited by the tumor may represent necrotic areas of the lesion, while other abdominal organs remain unremarkable. This was signed out as a case of gastric malignancy whereby histopathologic correlation is recommended. Biopsy was done which revealed a gastrointestinal stromal tumor. Gastrointestinal stromal tumors are the most common mesenchymal tumors of the gastrointestinal tract and accounts for 5% of all sarcomas. Cysts occur anywhere, and the most common sites of involvement include the stomach, to which 70% are mostly seen, the small intestines, and the rectum. So majority of cysts are sporadic, however, they appear to occur in the following syndromes: Carney triad, neurofibromatosis 1, and the Carney-Stratakis syndrome. So cysts appear as rounded soft tissue mass arising from the wall of a hollow viscus with an endoluminal or exophytic growth. Mucosal ulceration is present in 50% of cases, with large necrotic cavities communicating with the lumen. Appearances vary with size and location. Typically, the mass is of soft tissue density with central areas of lower density representing necrotic components. Calcification is uncommon. Metastasis or direct invasion into adjacent organs may be seen in more aggressive lesions. Lymph node enlargement is not a feature of this malignancy. The diagnosis of malignant gastrointestinal stromal tumors requires histopathologic correlation. Certain characteristics are connoted that may suggest malignancy, and this type of features develops in 10 to 30% of these lesions. So the following may represent malignant characteristics of a lesion: exogastric growth, diameter of greater than 5 centimeters, central necrosis, and extension to other organs. Thank you for listening.